Welcome to this Step 2 clinical knowledge review on high-yield test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most commonly tested question patterns across high-yield board topics and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to reteach the entire topic from scratch. Instead, we want to help you recognize classic vignette patterns and apply proven test-taking strategies. Make sure you have reviewed your first aid, your question bank, and pathoma before or alongside this video so you have the foundational knowledge to build on. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems across the most commonly tested Step 2 topics. Second, we will apply specific strategies for questions about chest pain, heart failure, and respiratory presentations. And third, we will master the next best step question format, which is the single most important test-taking framework on the entire exam. This video assumes you have some baseline knowledge from your review resources. We are here to sharpen your test-taking approach so you can answer questions faster and more confidently. Our first strategy is the chest pain split. When you see a vignette describing chest pain, the very first thing you want to do is decide whether this is cardiac or non-cardiac. Cardiac chest pain presents as substernal pressure that gets worse with exertion, often radiating to the left arm or jaw, with diaphoresis. You want to look for troponin levels and electrocardiogram changes. If you see ST segment elevation in 2 or more contiguous leads, that is an ST segment elevation myocardial infarction, and the answer is almost always emergent percutaneous coronary intervention. On the other side, non-cardiac chest pain tends to be sharp, pleuritic, positional, or reproducible on palpation. A tearing sensation radiating to the back is classic for aortic dissection. The boards love presenting these side by side and testing whether you can sort them quickly. Review the cardiology and emergency medicine chapters in your board resources for the foundational concepts. Strategy 2 is about heart failure classification. This is one of the most commonly tested topics on the boards. You need to be able to quickly distinguish systolic from diastolic heart failure based on the clinical vignette. For systolic heart failure, also called heart failure with reduced ejection fraction, you will see a dilated heart with reduced pumping function, an S3 gallop, and signs of volume overload like crackles and edema. The management here is well defined. Angiotensin-converting enzyme inhibitors, beta blockers, and diuretics are your go-to medications. For diastolic heart failure, or heart failure with preserved ejection fraction, the ejection fraction is normal, but the patient still has congestion symptoms. These patients are usually older with hypertension. The keyboard distinction is that the ejection fraction determines your treatment approach. Always look for the ejection fraction number in the question stem. Review the heart failure sections of your cardiology resources to solidify these concepts. Let us go through the classic stem patterns you will see on test day. For community-acquired pneumonia, the boards love giving you a patient with productive cough, fever, and a lobar infiltrate. The key decision point is whether this patient needs to be admitted or can be treated as an outpatient. Look for severity markers like altered mental status or hemodynamic instability to guide that decision. For pulmonary embolism, the classic stem is sudden onset dyspnea with pleuritic chest pain in someone who was recently immobilized or is on oral contraceptives. The chest X-ray is often normal, which is a major clue. Computed tomography angiogram confirms the diagnosis. For acute coronary syndrome, you are looking for crushing substernal chest pain with diaphoresis. The electrocardiogram and troponin levels tell you whether this is an ST segment elevation, myocardial infarction, or a non-ST segment elevation event, and that distinction drives your management. Review the cardiology and pulmonology chapters in your board resources for the detailed treatment algorithms. Here is your first practice question. Read the stem carefully. We have a 55-year-old man with classic cardiac risk factors, hypertension and diabetes, presenting with substernal chest pressure, radiating to the left arm with diaphoresis. His electrocardiogram shows ST segment elevation in the inferior leads. Before we reveal the answer, take a moment to think about what pattern you are seeing and what the next best step would be. Think about what those ST segment elevations in contiguous leads mean and how that changes your management compared to a non-ST segment elevation event. Let us walk through this answer together. Step 1. Spot the pattern. You have a man with classic risk factors presenting with substernal pressure, arm radiation, diaphoresis, and ST segment elevation in contiguous leads. That is a textbook ST segment elevation myocardial infarction. Step 2. Apply the rule. The board rule for ST segment elevation myocardial infarction is emergent reperfusion. If the hospital can do percutaneous coronary intervention within 90 minutes, that is the answer. Step 3. Eliminate wrong answers. Choice A, serial troponins, is part of the workup but is not the next best step when you already have ST segment elevation on the electrocardiogram. Choice B, heparin drip and admission, is the approach for non-ST segment elevation acute coronary syndrome, not for ST segment elevation. Choice D, thrombolytics, is only appropriate when catheterization is not available within the 90-minute window. The correct answer is C, emergent percutaneous coronary intervention. Review the acute coronary syndrome algorithms in your cardiology resources for more detail. Here is your second practice question. We have a 35-year-old woman with sudden dyspnea and pleuritic chest pain 5 days after knee surgery. She is tachycardic, tachypneic, and hypoxic. Her chest X-ray is clear. Think about what risk factors are present and what that normal chest X-ray tells you. What is the most likely diagnosis and how would you confirm it? Take a moment before we go through the answer. Let us break down this answer. First, read the question carefully. This patient has every classic feature of a pulmonary embolism: sudden onset dyspnea, pleuritic chest pain after recent surgery, tachycardia, hypoxia, and a normal chest X-ray. The normal chest X-ray is actually a clue because pneumonia and pneumothorax would show findings on X-ray. Now, why does the computed tomography angiogram win here? Choice A, D-dimer, is a great screening tool for low-probability cases, but this patient just had surgery. Post-surgical patients have elevated D-dimer levels regardless, so it will not help you. Choice B, a ventilation perfusion scan, is an alternative, but is less definitive and takes longer. Choice D, lower extremity ultrasound, can find the source of the clot, but does not diagnose pulmonary embolism in the lungs. The computed tomography angiogram directly visualizes the clot in the pulmonary arteries and is the standard diagnostic test. The correct answer is C. Review the pulmonary embolism workup in your pulmonology and emergency medicine resources. Now let us talk about heart failure treatment, because this is a board favorite. For chronic systolic heart failure, the mainstays of therapy are angiotensin-converting enzyme inhibitors and beta blockers. These medications have been shown to improve survival. You add diuretics to manage volume overload and symptoms. For patients who remain symptomatic despite optimal medical therapy, aldosterone antagonists like spironolactone are added. If a patient cannot tolerate angiotensin-converting enzyme inhibitors, the alternative is hydralazine plus nitrates. For acute decompensated heart failure, the approach shifts to intravenous diuretics and vasodilators. The keyboard pearl here is about beta blockers. If a patient is currently on a beta blocker and presents with acute decompensation, you can continue it at a reduced dose unless they are in cardiogenic shock. But you should never start a beta blocker during acute decompensation. The boards test this distinction frequently. Review the heart failure treatment algorithms in your cardiology resources. Here is your third practice question. We have a 68-year-old man with chronic obstructive pulmonary disease who presents with worsening dyspnea, productive cough with purulent sputum, fever, and hypoxia. His chest X-ray shows a lobar infiltrate. Think about whether this patient needs inpatient versus outpatient treatment and what empiric antibiotics would be appropriate for his setting and risk factors. Take a moment to think through this before we go to the answer. Let us break down this pneumonia question. First, spot the classic pattern. You have an elderly patient with chronic lung disease, fever, purulent sputum, hypoxia, and a lobar infiltrate. This is textbook community-acquired pneumonia requiring inpatient admission. The key distinction is the treatment setting. Choice A, oral amoxicillin alone, is appropriate for a young healthy outpatient with no comorbidities. That does not fit our patient at all. Choice C, oral levofloxacin, is a respiratory fluoroquinolone that can work for outpatient pneumonia with comorbidities, but our patient is hypoxic and needs inpatient care. Choice D, vancomycin plus piperacillin tazobactam, is way too broad. That regimen is for hospital-acquired pneumonia or healthcare-associated pneumonia, not community-acquired pneumonia, in an otherwise non-hospitalized patient. The correct answer is B, intravenous ceftriaxone plus oral azithromycin. This is the standard inpatient regimen for community-acquired pneumonia: a beta-lactam plus a macrolide. Review the pneumonia treatment guidelines in your infectious disease and pulmonology resources. This is probably the most important slide in this entire video, so pay close attention. The next best step question format is the most commonly tested format on the board exam, and it trips people up because there are often multiple answer choices that are technically correct. The key is understanding that they are asking what you do right now, not eventually. The framework is simple: stabilize before you diagnose before you treat, and always address the most life-threatening condition first. If a patient is crashing, the answer is never a diagnostic test. It is resuscitation. If a patient is stable, the answer is usually a diagnostic workup before jumping to treatment. When you are stuck between two answers, ask yourself which one comes first in the real-world sequence. Airway, breathing, and circulation always take priority. Imaging comes before invasive procedures. Labs come before empiric treatment unless the patient is in extremis. This framework works across every single organ system on the exam, from cardiology to surgery to obstetrics. Master this approach and you will see your question bank scores improve immediately. That wraps up our high-yield Step 2 Clinical Knowledge Test-Taking Strategies video. Let us quickly recap what we covered. We learned how to split chest pain into cardiac versus non-cardiac causes. We reviewed heart failure classification and treatment. We practiced 3 board-style questions covering acute coronary syndrome, pulmonary embolism, and community-acquired pneumonia, walking through each answer choice to understand why the correct answer wins and why the wrong answers fail. And we covered the most important test-taking framework on the entire exam, the next best step approach. Now here is what I need you to do. Go back to your first aid, your question bank, and pathoma. Review the cardiology, pulmonology, and emergency medicine chapters with these strategies in mind. Practice applying the next best step framework to every question you do. If you want personalized tutoring or help with your residency application, visit roadmaptoresidency.com, where our expert tutors and residency advisors are ready to help you. Please like this video and subscribe to our channel for more high-yield board review content. Good luck on your exam, and we will see you in the next video.